Assalamu alaikum. The vast majority of cases of sore throat are self-limited and would resolve spontaneously within a week or so, even without antibiotic treatment. But there are some sinister causes of sore throat, including scarlet fever, that, if not recognized early and treated promptly with the appropriate antibiotic, may run a complicated course. Scarlet fever is an exotoxin-mediated systemic disease caused by Streptococci group A beta-hemolytic strep. These secretes an exotoxin that is now termed streptococcal pyrogenic exotoxin (SPE). The risk of scarlet fever posing is now far less severe than what it was 2 centuries ago. The death rate then was almost 1 in 2. But since the introduction of penicillin, this has changed dramatically, and scarlet fever is now much less common and fatality is extremely rare. However, the gradual decline in the incidence of scarlet fever worldwide continued until 10 years ago, when a resurgence of the cases of scarlet fever was noted starting 2014. In England, the incidence of scarlet fever increased threefold in that year, from 8.2 to 27.2 per 100,000 population. And that increased further in 2015 to 30.6 and further in 2016 to 33 per 100,000 population. This led to the highest number of scarlet fever cases in England since 1967, approaching over 19,000 cases, and hospital admissions because of scarlet fever almost doubled. The same trend was also noted in Asia, in Vietnam, where the reported cases increased to 23,000 cases compared to 19,000 in England, and in China, where it amounted to almost 100,000 cases. Small outbreaks had also occurred in the USA and similarly in Canada. Annual variations in the incidence of scarlet fever was noted for quite a while. It was noted that every 4 years or so there would be a rise in the number of scarlet fever cases, followed by a repeating of the cycle after another 4 or 5 years. But nothing compared to the magnitude of the surge of the cases that has been noted in the last 10 years. Why? Why the resurgence of the scarlet fever cases? Perhaps because of multi-clones of beta-hemolytic, group A beta-hemolytic streptococci. Because they are multi-clones, one of them could be much more sinister than the other and can cause widespread and more infections. And because there are multi-clones, it's difficult to achieve population immunity because there are several clones of this. So a herd immunity is difficult to achieve. To support this, there was a variety of strains in the UK identified during the resurgence of the cases, and the same was also noted in China and other parts of Asia as well. Studies on the pathogenesis of scarlet fever suggested that the streptopyogenes scarlet fever organism grew into colonies, what they call a mat colony, large and irregular surface colonies, mainly formed because of abundant production of hyaluronic acid capsule polysaccharide of the organism. This is associated with the production of the M substance, the M protein, that used to be the umbrella term for the exotoxin of Streptococcus pyogenes. It's now called streptococcal pyrogenic exotoxin, SPE. There are at least 11 such toxins. Not a single one of them can cause scarlet fever on its own, but in some strains, like 4 or 6 of them, could combine together to give the manifestations of the disease. The SPE also plays an important role in the very severe cases of scarlet fever, where there is a systemic manifestation of streptococcal toxic shock syndrome. And in that case, it acts like a super antigen capable of stimulating cytokines receptors and secretions from large population of T cells, and this can cause the manifestations of streptococcal toxic shock syndrome. The symptoms are very nonspecific in the early stages, and it's difficult to diagnose scarlet fever in the first 24 or 48 hours. There will be an abrupt rise of temperature, often above 39 degrees, together with malaise, shivering, tachycardia, and headaches. There will also be sore throat and pain on swallowing, and a typical bad breath with some shortness of the breath as well, combined in young children with abdominal pain and vomiting. So that's very non-specific in the very early stages of the disease, the first 24 to 48 hours. But what is important is that cough, rhinorrhea, hoarseness of voice, conjunctivitis, or irritation or diarrhea are notably absent. These features would suggest more a viral cause for the sore throat rather than a streptococcal pharyngitis causing the scarlet fever. But within 24 to 48 hours, there will be some oral signs that will give a clue about the nature of the disease. There will be an exudative type of pharyngitis or tonsillitis with a grayish membrane over the tonsils and sometimes the posterior part of the pharynx as well. There will be soft palate petechiae that may extend over the anterior pillar of the tonsils, and there will be the white strawberry tongue caused by the coating of the tongue with whitish debris through which some of the tongue papillae could be seen. These are early signs, these three signs, early oral examination signs. Few days later, the tongue papillae would regrow and would show and become obvious on the tongue surface, giving the typical appearance of the red strawberry tongue. And these are the oral features of the scarlet fever. Examination of the face would show obvious flushing of the cheeks that has the ugly name of slapped cheek. This would be also a circumoral pallor. There will be a pallor around the mouth in contrast to the congestion of the cheeks. And the neck examination would show enlarged and tender anterior cervical lymph nodes, particularly the jugular-digastric nodes. 24 hours later, the skin rash would be noticed. This would be seen in almost all cases, about 90% of cases of scarlet fever, and in 70% of the cases they would start 24 hours after the sore throat and the oral and the facial signs. The rash would start in the groin or the axilla and will spread over the trunk bilaterally. It is formed of red minute papules, tiny papules that gives the skin surface fine irregularities. This irregularity gives the skin surface the roughness that give it the name of sandpaper erythematous rash. And pressure on the rash would cause fading of the erythema, except in areas like the wrist or the elbow, the flexor parts of the elbow and the wrist, where straight lines with a very distinct color would show on the pressing the rash. This has been called the Bastia lines. In about 6 to 9 days, the rash would start to desquamate. It starts in the face, behind the auricles, and extends in the axilla and the groin, but also in the palms and the fingers of the hand. You would see the desquamation of the skin, and this desquamation would dry up and peels off ultimately. The diagnosis is difficult to start with in the very early stages, where the signs and symptoms are non-specific, with high fever, tachycardia, and tonsil and pharyngeal yellowish membrane with anterior cervical lymph nodes enlargement. There will be some specific features like enlarged papillae on the tongue, giving the strawberry tongue appearance, and the petechiae of the soft palate. But it is the spreading of the bilateral trunk rash that results in a confident diagnosis. The other important feature is that About half of the cases would report another family member is also unwell because the disease is very contagious. The gold standard for confirmation of the diagnosis of strep pyogenes would be either a positive throat swab culture that would need to be collected properly from the throat by rubbing into the tonsils and the tonsil pillars only, and avoid touching the lips and the tongue. But the problem with throat swabs and cultures from throat swabs is that it would take few days for the results to show up. A more convenient and faster way of obtaining quite similar results would be the rapid antigen test, which will give the results in few minutes. It's highly specific with 95% specificity. The real advantage is immediate diagnosis, and this would obviate the need for the throat swab and culture and give the clinician the chance of immediate prescription of antibiotics. Serological assays for antibodies of strep pyogenes are not very useful. Measuring streptolysin or titr, for example, is not useful because it would take few weeks, 1 to 2 weeks, to start to rise in the serum after the onset of the infection and would reach the maximum level in 3 or 4 weeks. So it's not very useful in the diagnosis in the acute phase. The differential diagnosis would include causes for viral pharyngitis or tonsillitis combined with skin rashes like measles or rubella, or causes of fever accompanied by rash, and would also include things like infectious mononucleosis, Kawasaki disease, or the staphylococcal toxic shock syndrome. Antibiotic treatment for scarlet fever is obligatory. The treatment would shorten the duration and the severity of the illness, on average by about 24 hours. It also would prevent the chances of non-suppurative complications of strep pyogenes like rheumatic fever or glomerulonephritis. This may not be an issue in the industrialized countries, but in many other countries, resource-poor countries where the incidence of acute rheumatic fever is high, this is an important issue. Treatment would also prevent the suppurative complications of the strep pyogenes, including things like Coenses, sinusitis, and otitis media. And what is important in scarlet fever is that the treatment would reduce the spread of the infection in this very contagious disease, so it would help in controlling the outbreak. Penicillin has been the mainstay for the treatment of strep pyogenes for few decades, more than 50 years. It continues to be recommended as the first-line treatment in clinical practice guidelines worldwide. It has an established record of safety and efficacy and low cost and narrow spectrum, and it has not developed any resistance over 50 years of use. The other very good choice will be amoxicillin because it's similarly effective, it acts very quickly and is preferred for longer half-life, especially in children. The longer half-life would help in giving the patients twice daily or even once daily doses if needed. It's the beta-lactam antibiotics that are preferred treatment for the group A beta hemolytic strep infections due to their efficacy, safety record, and the low cost. Cephalosporins may be used in case of a history of penicillin allergy, but macrolides is not a very good choice because of the resistance to the macrolide is fairly common, and also because they have greater adverse effects than penicillin. In addition to the antibiotics, the symptoms can be controlled by either paracetamol or ibuprofen and plenty of fluid replacement. Scarlet fever is a notifiable disease, should be notified, and centers of education like schools and nurses should also be notified and encouraged to report such cases. The local complications would include peritonsillar abscess or retropharyngeal abscess. The non-suppurative complications for strep pyogenic infection would include acute rheumatic fever and glomerulonephritis. But there may also be, there are recorded cases of bacteremia, pneumonia, endocarditis, and meningitis. and rarely there will be also infections in the liver or the gallbladder, hydrops, or splenomegaly. Treatment with antibiotics had yielded very good recovery rates, and most of these complications were from case reports from the 1950s, but due to the high frequency of complications in the pre-modern antibiotic era. By this, we come to the end of this presentation on sore throat, the resurgence of scarlet fever. Assalamu alaikum.